Good morning, and thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Sarah Durena-Sedley with the New England QIN-QIO, and this is part one of our two-part webinar series on implementing TeamSTEPPS communication strategies in long-term care. Before we begin today's program, I have a few housekeeping items to review. This webinar will be recorded, and the presentation will be available within a few business days. The phone lines will be on mute for the duration of the presentation. We ask that you please do not put your line on hold. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. Please make sure to send your comments to all participants. Doreen from the QIN-QIO team in Connecticut will be monitoring and responding to questions and comments in chat. We will also have plenty of time for questions at the end of the presentation, and we'll open up the lines after that. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icons in the top right of the presentation window to adjust your screen accordingly. Now I'd like to introduce today's speaker, Ann Spenard. Ann is a Vice President and Principal at Callout, leading and directing business operations and quality improvement initiatives in the nursing home and long-term care setting. Her career has been focused on long-term care and geriatrics and leading national quality, patient safety, and data validation projects. She also teaches nationally to provider groups and the Centers for Medicare and Medicaid Services. She is also involved in multiple research projects and has published on many related topics to patient safety and healthcare quality improvement. Ms. Spenard currently works and provides managerial oversight to the New England QIN-QIO in the Connecticut, Vermont, and New Hampshire quality improvement teams. And I'm going to turn it over to you.
Good afternoon, everyone. Hi, this is Ann Spenard, and I'm excited to present today on TeamSTEPPS in long-term care. And I'm going to give you, let's see here. I'm just trying to move my slides forward. Hold on one second. Okay. Sorry, I needed some technical assistance here. We had a team. We worked as a team together for me to be able to present the slides. So anyway, so our objectives today are to, I hope by the time that we finish our program today, that you'll understand and be able to describe TeamSTEPPS for long-term care and the importance of communication related to patient safety. And we will address the issue around recognizing the connection between communications and medical errors, and we will be able to define communication and discuss the standards for effective communication. We'll talk about strategies for information exchange, and then we're going to wrap it up with identifying barriers, tools, and strategies and outcomes to improve communication. So TeamSTEPPS. So what is TeamSTEPPS? Well, TeamSTEPPS is team strategies and tools to enhance performance and patient safety. And this initiative is based on an evidence derived from team performance, leveraging more than 25 years of research coming out of the military and aviation, nuclear power, business, and industry to acquire team competencies. The idea behind this is all the work that was done in crew resource management and aviation, where we used to have a lot of plane crashes and people were dying, and then certainly coming out of the Department of Defense. And so there were all these high-risk situations. And so the idea was, wow, the aviation industry and Department of Defense are using these wonderful tools and concepts. Could we, in theory, apply some of this to healthcare? And so out of that genesis was born this idea around TeamSTEPPS. And it was a collaboration between the Department of Defense and the Agency for Health Research and Quality, and a whole variety of people that worked together to develop the initial TeamSTEPPS. So you can see here it was the Agency for Healthcare Research and Quality, research organizations, universities, business schools, quality improvement organizations, nursing homes. All of these things came together to develop TeamSTEPPS. And then we were able to take that. It was introduced into the hospitals around 2006. What happened with TeamSTEPPS is it was quite successful, and it continues to be successful in its strategies used in the hospital setting. And then it was in November of 2012, it was adapted and put out there for long-term care. And the idea was the evidence behind it, the key concepts, which were proven and worked really well in the acute care setting, then were adapted with keeping the evidence behind it, but changing the words from patient to resident and having specific scenarios that anyone working in the nursing home industry and long-term care would then be able to say, oh, okay, I can identify with that, and I can see how I can apply these key strategies in my setting versus just having to see it in the acute care setting and say, well, how would that work in a nursing home? So what I wanted to do is to give you kind of an overview. If we were going to do the whole TeamSTEPPS program, what are the key components or modules within that? And so you'll see here there's basically 7 modules that encompass the whole TeamSTEPPS program. It starts with a nice, really introduction and goes through kind of I gave them a very encapsulated version of how TeamSTEPPS came to be, but it talks about the key concepts and why it was developed, how it was developed, and testing related to that. And so that's that introduction. Then we go into, if you were taking the full program, talking about team structures, what are teams, what are core teams, what are ancillary teams, support structures, and whatnot, that then make up the various people that you must work with and communicate with. There's a module on leadership and the role of the leader, and within teams, formal leaders and informal leaders. There's a module on situational monitoring, and there's a lot of great tools and concepts within that. Then there's one around mutual support. So how do we have each other's back, not to stab each other in the back, but to support each other so that we have the best outcomes in supporting each other and having the best patient or resident outcomes. Today, we're going to talk about Module 6 around communication, and communication is so critical, and so I'm really pleased that this is a module that CMS has asked us to support within the work that we're doing around improving quality of the care and the outcomes for our patients. Communications is critical in that. And then Module 7, if you were taking a full course, is really pulling it all together, and then how do you operationalize this in your organization. So what I wanted you to have an idea about the core pieces of TeamSTEPPS, and we're just doing one piece of that today. So why do errors occur in the care that we provide and some of the obstacles? Well, there's workflow fluctuations, so we can understand that, the ebb and the flow. For those of you who are nurses on the line, med pass treatments, getting interrupted, getting a call back from a doctor or a practitioner and having to stop what you're doing, go answer the call, whatever it is, and then come back onto task. And so we know that that is an issue, so that's the interruptions. We have times in our work day where it's very intense, lots of things going on, and then areas and times in our day maybe where it's a little quieter. Fatigue can play a major issue in why errors occur. If you're doubling back, if you are on your 12th shift in a row, you haven't had any downtime, if you're dealing with family issues, a sick child, whatever, you're tired, and you come in, there's been lots of studies done around sleep deprivation and driving, right, and having accidents. that fatigue factor is almost like being, if you were impaired by having drugs or alcohol. Well, it's the same thing, and if you think about it, the work that we do on a daily basis in caring for our patients and our residents, and it doesn't matter whether you're a social worker, whether you're a CNA, part of the maintenance team, dietary, fatigue can play a factor in that. Multitasking. We are asking people on a daily basis to do much more than just one thing. It's like, oh, do this, and at the same time do this, and observe this, and whatnot. So our concentration, our energy is being pulled in multiple directions. Failure to follow up. So that's closing that communication loop and following through on things. Poor handoff. So if we're going to talk in more detail about this, but if I hand over care, even if it's just simply when I'm going to lunch and I'm leaving the unit and I'm going maybe down to the cafeteria or to the lunchroom area, and I'm handing my care, whether I be a CNA handing my residents off to another CNA, or whether I be a nurse handing off to another nurse, and I'm relieving myself from that unit and handing off. If I don't communicate that handoff very clearly, then there's certainly great risk. And then we have handoffs from shift to shift. We have handoffs from unit to unit, and we have handoffs from facility to facility. So there's lots of opportunities, and we're going to talk about that, how critically important communication is around handoffs. We'll talk a little bit about some strategies around ineffective communication. So if we don't clearly articulate the information, we give too much information or not enough information, how do we streamline how we communicate so that we make sure, as the center of the communication, the person receiving the information is getting everything that we intended them to get. And then certainly not following policies, procedures, or protocols can be an issue around errors. One of the other things that have come into play, and if you were taking the full TeamSTEPPS course, with this idea of excessive professional courtesy. What does that mean? Really, and the halo effect, it kind of goes in together. And what it's saying is, I'm not going to question you, the doctor, the HRN, the supervisor, even if my gut is telling me something's not right. The whole idea around TeamSTEPPS is anyone can stop the line, and that idea meaning if it's around patient safety, you not only have the right, but you have the obligation to speak up. And this is just kind of globally giving you the concepts around this. This idea of a passenger syndrome I thought was quite fascinating, and a passenger syndrome is, well, I'm not driving, and I'm just along for the ride, meaning I don't care that I see that you're driving straight on into a lake. I'm just going to let you do that. I'm going to let you fail. People with hidden agendas, setting really, they want to maybe not protect their coworker, and they're allowing them to fail, but by them allowing them to fail, it actually can hurt a resident or a patient. Complacency, I'm kind of burnt out. I'm not gonna put the effort into what I need to do. Then there's opportunities around things, the high-risk phase in a process or a part of care. Someone getting too focused on the task, and this can happen in nursing homes very easy. You take a well-educated licensed LPN or LVN and or an RN, and they put like blinders on, and it's around pushing the pills or getting the treatments done. Instead of saying, when I'm going in to give medications, I'm assessing everything. How the person greets me, how they're communicating, what do they look like, how's their posture, what's their baseline to compare to what I'm saying. And what you do is that people just, they go in and they're just doing a task and not being a good observer of everything that's going on around them. So what are the components of resident safety? So I'm giving you this kind of umbrella, and then we're going to take it down into the components around communication. In the center, you see the resident or person-centered care, and then there's a circle around them that is this idea around a culture of safety. And you can actually measure the culture of safety in your organization through the Agency for Health Research and Quality has the Nursing Home Patient Safety Culture Survey. And if you never had the opportunity to be part of that, it's free. You can go out and get the tool. There's an electronic tool. They'll do all the data analysis, and there's all this robust back end that will give you feedback reports on how your organization, how your staff within the organizations perceive the culture of safety in your organization. It's very, very informative. And as a leader, that's something that organizations may want to do, because then what it's going to do is tell you where there's opportunities where the staff's perception may be different than what leadership's perception is. And I can tell you that the research out there shows that leaders in organizations, specifically long-term care organizations, rate the culture of safety much higher than the staff's perception of it. So there's a disconnect there, and I think there's an opportunity there. But around this culture of safety, we have team training, which is what we're going to be talking about today, or one piece of it. We have innovations and lessons learned. So if you're a constantly learning organization, reporting and data collection, so how are you using your quality measures to drive quality, what's your quality assurance and performance improvement program, any research or development, what does the current evidence tell us about the care that we're providing, education for all of our staff, education of our residents and their families, organizational sharing and collaboration, which is this environment that you have within the New England QIN-QIO. There's some great innovations happening in various states, and so sharing that, and I think that the New England QIN-QIO has done a nice job of sharing best practices and innovations that have happened, so that's a wonderful part of being part of this group. Process improvement, all around quality improvement, that's what we in the New England QIN-QIO do on a regular basis. And then we have regulatory compliance, right? The rules and regs are there, often not to stymie how we care and provide daily services to our residents, but they're there also to safeguard. So some of the infection control policies and procedures and whatnot. So now we're going to start to delve in a little bit into communication. So teamwork's all around us. And if you think about it, if you're playing on a team, if you're part of the military, in healthcare, definitely we're part of teams. You may be part of teams in other organizations that you belong to. Maybe you're part of a group or a pseudo team within whatever religion that you practice. And so you should always reflect on all of these times when you're working with groups of people, how do we communicate? So a lot of these skills we're going to talk about today, you can apply just to your life. And how does your family unit work? You kind of are a team. So how does the various groups that I have, what are their strengths and what are their weaknesses, and what can I learn on how they communicate? So you're going to see these slides. These the format of these slides, this TeamSTEPPS slide here, come right out of the Agency for Health Research and Quality and their curriculum. And you can go out, if you search TeamSTEPPS Long-Term Care, it will take you right to the Agency for Health Research and Quality's website. And you can pull down all of these training materials. You can pull down the instructional design, which will tell you how to do train the trainer or actually do initial training in your facilities. There's all kinds of resources. There's video vignettes that I'd hoped to embed as we move along. It didn't work out that I was able to do it, but you can access those and look at those examples of various skills. And I think there's one thing to talk about them, it's another thing to see them in action. Or you can reflect in your own organization, how would this happen? So what comprises team performance? Well, it's the knowledge or the cognition or the thinking piece of it. It's the attitude, the affect or the feel, and then it's the skills or the behaviors. So knowledge, attitude, and skill build in around that. And if you look at this triangle around here, you have the patient care team surrounding, and in between, in the center there is some of these core competencies, and communication being the one to the left or in the purple as being one of the core competencies. So that's, for everything that we talk about, we're going to think about the knowledge, the attitudes, and the skills that each staff member may have around them. So some of the outcomes of team competencies are having knowledge and if you were going through the whole TeamSTEPPS program, you would learn about a shared mental model, and that meant if I was describing to you and I'm communicating to you about a fish, that by the time I was done, you would understand that the fish that I was describing to you was a salmon, and maybe a very particular type of salmon. And you as a receiver would say, oh, I'm getting this. It's a fish and it's a salmon. And so you're not thinking of a river trout when I'm trying to describe a salmon to you. So that in that communication, we both understand what we're talking about to mean the same thing. So that shared mental model is important. Attitudes, trust is a big piece of this. To be part of a well-functioning team, we need to have mutual trust and understanding. And team orientation, part of this is understanding how do I fit in the team and what are my roles and responsibilities within the team, and what are my obligations within the team. And part of that team is your resident and the family. So we've got to think about that also. And then around performance, adaptability, accuracy, productivity, efficiencies, and safety all fall into place here. So the importance of communication. Ineffective communication is a root cause of nearly 66% of all sentinel events reported. So this came out of a paper that the Joint Commission wrote. And what they did is in a sentinel event, and I think most people know what it is, and that there are certain events that happen that, especially if someone dies, that if you're a Joint Commission accredited organization, that you have to report into the Joint Commission. So this is only based on those organizations that are part of Joint Commission and meet this very narrow tip of an iceberg, if you think about it, the very, very tip, very narrow definition of what must get reported in as a sentinel event to the Joint Commission. That being said, as I'm describing this is a small percentage of all of the potential issues and concerns that are happening in all of our healthcare organizations. But what they found when they did, so if you had a sentinel event, you had to do a very deep dive and do this, what we call a root cause analysis. Hopefully I'm not talking language that doesn't resonate with you, but a root cause analysis says, let me keep asking the question why, and I think you've already been oriented to that. Minimally, you have to ask the question why at least 5 times, and it may be many more times that, so that you can figure out down to the base or the root what impacted why something happened. And it's usually multifactorial. But one of the things that they found is that communication played a role in nearly 66% of all sentinel events reported. And I would guess today, as we've gained a knowledge in this area and we've become much more savvy, that if you're really honest with yourself, communication probably plays on some level of lack of communication or inappropriate communication or something, failure in communication happened or impacted in probably almost all sentinel events. If you step back and say in your own organization, as you've done, let's say you're doing an evaluation on a fall, or you are looking at a system failure within your organization, more likely than not, you're going to find some sort of failure around communication. So it's critically important. So talking about communication, and you'll see throughout these slides, you'll see these emperor penguins. And I just want to address that. So these emperor penguins came out of a book that was My Iceberg is Melting. And what it did is take the idea of Cotter's theory of change, and he wrote this very kind of fun, quick read, but very impactful book around all the skills and strategies and stuff that you must have to change culture in an organization. And Cotter has 8 steps of change within it. So they took that change theorist, and it's woven into everything that is done related to TeamSTEPPS, and then they have these penguins. Now, an interesting thing as this was adapted for long-term care, Michelle Pandolfi and myself from Callout were part of the team that adapted these materials. and we actually had to get some new penguins drawn that was more reflective of some of the roles and responsibilities in nursing homes and what would be equivalent to like the patient, aka a penguin, in long-term care. So we put in walkers and wheelchairs and some of the other things that are reflective of us. But here in this situation, what we're looking at is the source who's giving a message to a receiver, who then receives it and hopefully gives back feedback that they in fact received the accurate message. And then in the middle, you see those kind of ice blocks, and what that is could be a potential wall, or these are areas that could impact the source of the message getting over to the receiver and the receiver getting the proper message in return. So you have things like assumptions. Oh, I assume I know what you're saying, and I'm jumping to conclusions, and I already know it, and I'm going to take off and run, and I didn't listen to what you were telling me. I assumed I already knew what you were going to say, so I wasn't listening. Fatigue, so I'm not paying attention to the task as clearly as I need to. Distractions, there's lots of other stuff going on, so I'm not really listening to you. I'm kind of half listening. And I think we all can relate to that on a daily basis. And then this big thing called HIPAA, and we are only giving partial information because we're trying to either properly interpret HIPAA or we're misinterpreting HIPAA and we're not clearly communicating to someone who would be authorized to receive information and then be able to carry out and take care of our residents. So in a nutshell, communication is a process in which information is exchanged between individuals, departments, or organizations. So if we're communicating to the ambulance who's picking up someone, to a physician office or a specialty office, when we're sending one of our residents out for care, if we're transferring someone to the emergency room, or if we're sending someone out back home and now we're communicating with the family and maybe the home care agency. And communication is the lifeline of the core team, and that's everyone that's caring on a daily basis for someone. We have to clearly communicate on a daily basis. And it's effective when it permeates every aspect of an organization. And the idea here is you want to really almost over-communicate, but you don't want to do it so that it becomes noise. So it has to be purposeful communication, it has to be clear and concise, and we'll go through a little bit more of that as we move along. So there's some standards of effective communication. It's complete, it's communicating all relevant information, it's clear, we convey the information that's plainly understood, we're not adding a lot of superfluous information that really doesn't need to be there. It's brief, it communicates the information in a concise manner so that I clearly, if I have limited time to listen to you, I'm going to get the message and I'm going to get the key concepts within the message. And then it's timely. It offers the requested information in an appropriate time frame. You verify the authenticity of it so that you know that you're getting it from a primary source where you can. And then you're validating or acknowledging the information so that you may be, like you're taking a physician order, I think we have an example of that. You're writing down that order into the medical record and then reading that order back to a practitioner so that you are validating that you heard exactly what they're saying. Here's just a pictorial, and this comes right out of the My Iceberg is Melting book. There's a sign here that says, notice public water. Our public water is currently closed because it is not open, the management, meaning there's just a whole lot of words. What was the key message that needed to be there? And then we have someone timely, the sign going up saying, seals in the water don't swim, or danger, yeah, seals in the water don't swim, and yet they have people, they have penguins already in the water, and so the message didn't get out in time to potentially save them or impact them. And then how clear do we communicate? I think that's one of the areas where we all can work nicely on. So many of you, I would beg to say that all of you on the phone, if you've done any of the Interact work that's happened for the last couple of years, have already about SBAR, Situation Background Assessment and Recommendations, as part of the Interact. So I won't spend a whole lot of time, but it is critically important. And SBAR came out of the military. Can you imagine if you're under fire and you have a very, you're able to communicate back to maybe your support forces and say, here's what's going on. We're taking direct fire. We were tasked to move into this particular area and do these things. That whatever it's critically important. Here's my current assessment. We're locked in. There's nothing I can do. You need to help, open up an area that we can escape from. And here's our recommendations that you send in air power. I don't know. I'm not military, so I apologize to anyone out there who's military. You can talk about that, but those are some of the examples. And we can certainly use that in healthcare. One of the things I found in long-term care when I've taught this, and I've taught it a lot, is nurses in long-term care are not as strong as I think they could be in the recommendation to a practitioner. Because, this is the opportunity. Often we're calling, so we don't have eyes on. We don't have body language or anything. What are your recommendations? If you have eyes on that patient or that resident and you're calling a practitioner, how toxic does that person look? Do you think, oh my goodness, this person needs to go out? Or this person needs to be seen in the next 24 hours, or whatever. So be very clear in what you're kind of seeing and feeling and what you're thinking should happen. Could we do watchful waiting? If someone has something's not quite right, they're not running a fever, we've done all these assessments and whatnot, can we push fluids, can we monitor vital signs, and then if anything changes, then get back to the practitioner. And then we'll talk about some skills around call-out, check-back, and handoff. So let me just get into some of these skills. We already talked about this already. So situation, what's going on with the resident, what is in the background, what's the clinical background or context, what's critically important. Not every diagnosis they have, not that they have 3 children and, 4 great-grandchildren. What does a clinician or whoever you're trying to communicate need to know background related to whatever you're communicating them to, whatever the issue is. Assessment, what do you think the problem is, and give data. Was there a change in medication? What are your vital signs? What's going on? What have you done in your assessment of that patient, and clearly articulate that to whoever you're talking to, and then recommendations. And then in red here, it says remember to introduce yourself. Always, there's people out there who teach this is ISBAR, meaning introduce yourself first. So this is Ann from Happy Holiday Nursing Home, blah, 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 blah. So that they know who exactly that you're talking to. And you could say maybe I'm the supervisor, or I'm the director of nursing, or I'm the unit manager, whatever it is. And so there are some exercises and things that you can do. I'm not going to spend a whole lot of time since you've done SBAR, but if you were sitting in a small group, this is something that you could practice during a unit meeting. And just ensuring that people really understand how to use SBAR. And I would recommend that as they're going through this, are they being concise in the situation? In the background, are they giving too much information or not enough critical information? So let's say, for example, the patient had a fall and was on warfarin. You'd want to make sure that you communicated that the patient was on warfarin, because practitioners will treat that patient a little differently than they would if someone who had a fall who was not on warfarin. That's just one example. The assessment is the person able to gather the right pieces of information and then communicate that. And then I think the greatest opportunity lies within what are the recommendations. So a call-out. So call-outs we will use in long-term care. It's a strategy used to communicate important or critical information to a group of people or team members. It informs all team members simultaneously during an emergency situation, and it helps the team members anticipate the next steps. So what kind of situations would you do a call-out? Well, if you had a person who either, let's say, had a fall, who's still on the floor, you're assessing them, you're trying to figure out, do they have a fracture, did they pass out, what's going on, or the sudden change in condition, you may have 2 or 3 or 4 staff members in the room, and so a call-out could be a blood pressure, a pulse ox. If I'm applying oxygen at 3 liters nasal cannula and their pulse ox now is blah. What you're doing is then everyone in the room knows what's going on. It could be another ancillary staff member coming in and just saying, level setting, paperwork is done, 911 is called, they will be here, they're 4 minutes out, I've got the elevator held, is there anything else that anyone would need? So you're informing the whole team instead of just telling one person and then expecting everyone else to then repeat it. So it's communicating critical pieces of information. Okay. So that's a call out, and we can use that in various ways. And I'm giving you clinical examples, but all of these strategies could be just as easily used in let's say in dietary or in laundry or in maintenance. It could be used when you have a weather event going on. And then within TeamSTEPPS in itself, there's all kinds of other tools. There's huddles and debriefs and whatnot. We're not going to go through all of those today, so I'm just giving you a sampling of some of the tools around communication. Check back is just closing the loop on the communication. So we have the sender. We talked a little bit about this in the earlier slide. The sender initiates the message. The receiver accepts the message, meaning, yes, I heard you, but provides feedback and confirmation that thanks, Sally. I heard what you said. I'm going to call. The message was that I should call Mr. Smith's family and explain blah, 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 blah. So now if that was the message that I had given, now what the person has done is closing that loop and saying, I heard you. I wasn't distracted. I wasn't fatigued. I was not half listening. I got not only what happens is sometimes people only get the first part of the message but not the second part of the message, and then we wonder why things fall through the cracks. And then, so the communicator communicates, the receiver receives and accepts, and then is closing the loop by saying they understand it. And then the original communicator is able to say, yes, that is the message that I've given. So think about that as a loop. And these are things that just really should be kind of the fabric of how you do things and become a good communicator, whether this be in your family or whether this be part of any kind of teams that you belong to. I'm going to spend a couple of minutes on handoffs. Handoffs is probably the highest risk area that we have in healthcare. And so what is a handoff? It's the transfer of information. But it's more than just the transfer of information. It's the transfer of information along with the authority and responsibility. So I gave the example early on around I'm going to go to lunch, and so you're going to cover me. Sally's going to cover me and Spinard while I go to lunch. And so I would hand off to you and give you, I'm waiting for Dr. Smith to call back on this patient, and here's what's going on. Here's what's going on with Mrs. Jones. She's not feeling good. Whatever the pieces of information, so that when I go down to lunch, in fact, I've given you enough information, but now you've accepted that because now you have the authority and the responsibility to care for my residents while I'm at lunch, or when we're, sending them to a new unit, or we're handing them off to another agency, meaning like home care or whatnot. During the transition in care, when we're doing the handoff, it includes an opportunity to ask questions, clarify, and confirm. So it's not that I'm just going to dump with you, blah, 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 and run out. I need, or part of a good handoff needs to be that if I need to ask a clarifying question, that you give me the time to ask that clarifying question, or to confirm what I heard, or to delve a little bit more, because now I am taking authority and responsibility for that care, and so that's a critical part of the communication. So this is where, and I'm not judging, but organizations who tape their report. So that's a one-way piece of it's a handoff of information one way, and there's no opportunity for clarity, confirmation, or questioning. So I think if you think about your own organizations and you reflect on how do we communicate, and I understand about efficiencies and overtime and everything else, but when it comes to patient safety, we may need to say, is there some sort of overlap, even for a few minutes, where someone can listen to report if that's the way we're going to do it, and then have an ability, some way, to get clarity or to confirm or to ask questions. Because if not, I think it's a gap within your systems and something that you may want to look at. And we So when we're doing a handoff, it optimizes information, responsibility. We talked about that. There's checklists you can use, thinking about how with handoffs is there other ways, checklists, IT support, acknowledgement, this is where we have our greatest opportunity or our weakest link every time we hand off care. I had tried to embed, you'll see this picture here, I was trying to embed a video, but if you go out to the ARC website, you can look at the variety of videos. They give you examples, both in a subacute setting and a long-term, traditional kind of more long-term care setting on various skills. So whatever staff that you're educating or training can relate to it. Another skill, this one is a hard one. It's complex. It's got many pieces to it, but it's around a handoff call. I pass the baton. Now, not everyone has adapted and used all of these skills. They take pieces that seem to work for their particular organization. But I put this slide in there because I think it's important when especially when we're handing over care, shift to shift, unit to unit, setting to setting, that we make sure that we're addressing many of these steps in it. And I is introduce yourself and your role or your job, and then identifies the patient, the resident, age, sex, and location. Then we have, so that's the P, then we have assessment, relevant diagnosis, complaints, vital signs, symptoms, whatever is going on. The situation, you see where some of this kind of is like SBAR, current status, maybe ADL status, it could be elimination, intake, and output, behavior, cognitive, and whatnot. It would include, especially if you're going to another level of care, if it's a co-status, are they comfort care, what's going on with them, level of uncertainty, recent changes, or response to treatments, anything that you're concerned about, you want to make sure that that's clearly articulated. Safety, are there any critical lab values or reports that you're waiting for? So, we've sent off a stat INR. So that's an important piece of information if I'm going off shift and we're waiting for that lab result to come in, because I probably want to keep an eye out that if I haven't heard back from the lab, that I'm then reaching out to the lab to get that information. It may be around allergies or alerts, so that they're at high risk for falls and what the strategies that we're doing. And then we have the word the, and then baton is background. You can read that here. Actions, what actions were taken or required, or things that need to be followed up on. Timing, what's the level of urgency or explicit timing or prioritization of an action, meaning we have to hear back from Dr. Jones today by 6 o'clock, or we're waiting to hear back from the family because then we need to take an action. So timing or the urgency of it, or can it wait till the next day? Ownership, who's responsible, including the patient or family responsibility. And then next, which is the N, is what will happen. What are your anticipated changes? What is the plan? So this is a more complex concept, but I think if you're teaching people around the key concepts around doing a thorough handoff, especially shift to shift, and definitely within organization to organization or floor to floor or unit to unit, these are key concepts that you want to make sure that people understand. And then within that, you see in red down there, questions, clarify, and confirm. There has to be a two-way communication so that the receiver has the opportunity to get clarity from you, the sender, on the information. So some of the challenges around communication, language barriers, and this could be the language barrier for the patient or resident and the family. It could be language barrier accents and stuff with staff members. It could be with the practitioners, the nurse practitioner, the PA, the MD. Certainly distractions, physical proximity. It's easier if you can be face-to-face and you're standing, right next to each other versus over the phone. Certainly communications. If someone, for the nurses out there, have you ever called the doctor and you want to give them the key pieces of information, even if you're trying to use SBAR, and they cut you off and they won't listen to everything that you have to say, that can be because they have this overbearing kind of personality. Your workload, so the opportunity to pay attention to things you need to pay attention. Varying communication styles. What we found is nurses communicate one way and physicians communicate or are taught to communicate differently. That's changing now as they're doing a lot of mixed education, meaning physical therapists, occupational therapists, and nurses and MD students all learning together, and piece of that is to try to improve the communication. Certainly conflict can be an issue or a challenge in communication. Lack of information or verification, meaning going back and looking at orders, progress notes, whatever it is. And then shift change. When you're rushing, I already talked about that idea. If you're having to tape report, there can be major challenges with that. So as we're winding down and getting to the point where we want to do some questions, this is a slide if you were taking and working through using TeamSTEPPS. At the end of every kind of module, we talk about the barriers to a particular topic. So in the red, you see the barriers to potential barriers to communication. In the yellow, in the middle there, are tools or strategies within the toolkit of TeamSTEPPS. If you think of TeamSTEPPS as a strategy or a set of tools and toolkits that you can help improve communication. And not that we covered them today. If there's interest, we can cover them at another time. But how to use, what is a brief and how to use it? What's a huddle? What's a debrief? What are some of these skills that could then help improve and mitigate some of the barriers that we have around communication. And then in the green are what are the outcomes? What do we hope to get out of this communication? If we have identified these barriers, we've put in these tools and strategies, what could be our outcomes? And hopefully that's around a shared mental model, adaptability of our staff and their ability to communicate in a variety of different ways, team orientation, mutual trust, a well and high-functioning team and team performance. And the biggest thing is resident safety on the back end of this, and that's really the ultimate outcome that we have. Some of the actions that you can take: communicate with team members in a brief, clear, and timely format. We gave you lots of skills around and tools to use around that. Seek information from all available sources, so certainly verbal communication, written communication, physician orders, progress notes, and whatnot, all may help to be able to communicate what is going on with a particular patient or resident, and then how do we communicate that. We have tools and strategies. There are 24-hour reports. There's shift reports that are written. There's other ones that are, maybe taped, and there also may be verbal. So we want to gather information from all these variable sources. We want to verify and share information, what's critical, and make sure we communicate it. And then practice communication tools and strategies daily. How do we implement this into our daily, just kind of how we do business? And we're seeing SBAR as one way that is becoming much more mainstream. It started the adoption in the hospital setting. Of course, TeamSTEPPS came out in the hospital setting. Became pretty much the standard way many people communicated in the hospital setting, and is infiltrating and is really starting to impact some communication within the skilled nursing or nursing facilities. So I just spoke for 45 minutes, and I gave a lot of information. I am a master trainer in TeamSTEPPS, and my doctoral work was around implementing TeamSTEPPS in long-term care. I'm incredibly passionate about this whole program. So I'd like to open this up for communication, to communicate with all of you, answer any questions that you have, and if in the chat box you want to put in other areas of interest around TeamSTEPPS that you might have, that would help inform us, like a QIN-QIO, about other opportunities to bring some more of this information forward to your organizations.
Just a reminder to ask a question. You can join us on the phone line by pressing #6, and make sure you also unmute your phone manually if you use the mute button on your phone. You can also ask a question by typing it in the chat box on the bottom right-hand corner of your screen. So the lines are open for questions for Anthem.
Sarah, did we lose you?
No, did you hear me speak just now?
Oh, yeah, I did. It sounded like you got cut off. I just wanted to make sure.
Oh, okay. Sorry about that.
Okay, so we have a question from Tanya Rowley. When will a Part 2 presentation of TeamSTEPPS be available as a webinar?
Great
So
question.
I
I can
think,
answer that. Go ahead, Ann.
no, Sarah, go ahead. I was going to say we have part 2, so you can tell them when that date is.
Yep, part 2 is on October 26th. It's a Thursday. It'll be at 11 a.m.
And Sarah, this is Morgan. Just to jump in, the thank you email that will be going out tomorrow will also contain a link to register for that Part 2 webinar, so be on the lookout for that.
And that Part 2 webinar, just so everyone's aware, will actually be, we're going to have a couple of facilities who have fully implemented TeamSTEPPS in their nursing homes, and to talk about their experience, the barriers, the successes, lessons learned. So we're very excited about that program.
Okay, we have another question from Carol Ann Hall. What is the next step to start TeamSTEPPS in your facility?
Well, that's great. That's a great question. So what I would suggest, depending on your organization and where you are, we certainly will look to see if we can provide more information on it. I would go out to the ARC website, and we certainly can get that website, the direct link to it. But if you did TeamSTEPPS Long-Term Care, it will take you out and you will see all of the modules and all the training materials and the videos. There's a idea to become what we call train the trainers, and that's the idea of how we're replicating TeamSTEPPS. It used to be you'd have to go to become a master trainer, you'd have to go out to a program. There's now some online training that you can do to take TeamSTEPPS. I'd have to research if there's a cost to that. But you can, if you wanted to go out and say, well, let me look at some of these other strategies in the areas, literally the materials are out there from a train-the-trainer perspective where it says, here's the slide. I've taught this so much, I don't need to read what it says, but it literally tells you what to say and what are the key concepts behind it, and how do you implement it. So there's a wealth of knowledge, and it's all free. This is out in the public domain, so it's all free use for anyone who wants to implement it within their organizations.
Okay, and Kathy, I just sent you the link for today's presentation to download it.
Do we have any other folks that are joining us on the line to ask a question? All right, so if we don't have any other questions, thank you very much, Anne. Thank you for everyone for joining today's session. If you weren't able to ask a question today, you can reach out to your QIN-QIO Nursing Home State Lead. Contact information is on the screen. Anne, would you be able to pass the ball back over to me?
Yes. I'm getting a consultation here on passing. We're passing it back over to you.
No worries.
This is Sarah. Coming right to you. There you go. You should have it.
Perfect. Thank you. Don't forget to mark your calendars with upcoming collaborative events and educational opportunities. Part 2 of this webinar takes place on October 26th. On November 9th, we'll be hosting a webinar on accessing your data reports from NHSN. And again, on December 14th, we'll be hosting a webinar on preventing and managing C. diff. So check out our website for more information and to register. Also, if you have not already registered for the the Dementia Care Symposium in Braintree next week. That's being hosted by the New England QIN-QIO and Beth Israel Deaconess Hospitals. It's not too late. We do have a few spots available, and we'll include a link in the chat for you to register or just check it out on our website. And if you've joined us on previous webinars, you'll know that we frequently have contests to win free passes to a face-to-face training or other educational events. This month, we're giving away 2 passes to next week's Dementia Care Symposium. So to enter, like and follow us on Facebook. The winner will be announced on Facebook next Monday morning. Here's a link for you to find us on Facebook. And following today's webinar, you will be directed to a survey to provide feedback on the webinar. Your input helps improve these educational sessions and provide you with meaningful programs in the future. Also, within a few business days, we'll be sending out an email to everyone that contains a link to both today's presentation and a recording of the webinar. Thank you all for attending today's webinar, and have a great day.